Hey, there's Dr. C. Good to see you this afternoon. And topic today is going to be arteriosclerosis. That's a big word, isn't it? But it is a very important thing, especially in our culture. Remember, hardening of the arteries, not necessarily hardening either, we'll explain that, but arteriosclerosis causes all sorts of problems. It is a major cause of death, for example, strokes, heart attacks, vascular disease in the system, a lot of stuff related to arteriosclerosis. Now, I always tell, I used to tell medical students, I don't teach them anymore, but I always tell them, diseases have not changed. What does change is our ability to diagnose it and maybe sometimes to treat it. But getting that disease is exactly the same. And so let's explain a little bit about arteriosclerosis. It begins in the wall of the artery. Now, the wall of the artery has 3 layers to it, a lot bigger and thicker than a vein, because it is propulsing under pressure the blood that's coming from the heart. It's going all over the body. So it's that inner layer now, that's called the intima, that inner layer of the artery. At all of the places where the artery splits, they call it a bifurcation, it splits. An artery comes off, like say it goes to a kidney, for example, or it goes to an organ, or wherever there is a juncture and a split. That causes a little turbulence in the blood flow. It is thought that turbulence causes, eventually, over time, causes a little defect in that inner lining of the artery. Then the LDL, the low density lipoprotein, that's the stuff that carries the cholesterol that you eat. It carries it so that it can go to the liver where it's going to be processed. And so blood is a water-based thing. Cholesterol is an oil base. So that's why you need that lipoprotein. And there's 2 major lipoproteins. There's others too, but 2 major ones, the high density HDL and low density LDL. It's that low density lipoprotein that will get in through that intima, that lining of the artery. Now that sets off several reactions. Number 1, it'll set off an inflammatory reaction, inflammation. And inflammation will draw other cells to that area where that LDL has gone. It may draw in some cells as well. And those are the white blood corpuscles. So it draws them in. Now, when a thing called monocytes, that is a larger round cell, white cell in our body, when a monocyte goes through, it then turns into what they call a macrophage. Now, the macrophages are there in order to clear things. In other words, macrophages will clear, for example, bacteria. They'll clear foreign substances, but they will also clear some of that LDL as well. And so as these macrophages get larger and engulf all this stuff, they become what they call foam cells. Now, this stuff will get oxidized. The foam cells will eventually die. In other words, there's some necrosis there as well. That stimulates stuff to come down into that area of the artery. Now, the stuff that comes is now mixed with the cholesterol that was in that low-density lipoprotein, and it becomes what we call a plaque. So it accumulates plaque under that lining of the artery. I'm trying to make it as simple as possible for you to understand. So this continually goes on, and it builds, and it builds, and it builds. And as it does, it narrows the artery down. So they call this then occlusive arteriosclerosis, narrowing down of that artery. Now, when an artery narrows down to roughly about 80% of the circumference, now there's only 20% of the amount of blood getting through that area. Now it will drop the blood pressure on the other side of that obstruction and cause symptoms. So with that as basic physiology now, basic physiology. And one other thing. There's another way that it can cause symptoms other than narrowing it down. It can also weaken the wall of the artery so that the wall now expands and it becomes what we call an aneurysm, which is an expansion of the entire wall of that artery. And aneurysms are a problem because they can rupture. Now, there are common areas where all of these things tend to occur, both the occlusions and the aneurysms. Let's first deal with, very quickly, deal with the aneurysm. They tend to occur in several spots. The abdominal aorta. The aorta is the big blood vessel that comes down right off the heart. And you can get aneurysms in the top part. That's called the arch of the aorta. In the chest part, thoracic aorta, and in the abdomen, abdominal aorta. You can also get them in the larger arteries that are coming down off the aorta, going into the legs, iliac arteries. You can get it in the femoral artery, where you can feel it in the groin. And you can get it in the popliteal artery, down under the knee. Those are the common areas in the main aorta. And then you can also get little aneurysms in the brain. Those are the kind that don't cause any symptoms. And all of a sudden, you get a headache and you say, oh man, that is it. It's expanding, it's rupturing, I'm dead. Woo! And believe it or not, people have said that. So, yeah, those are very dangerous, those little ones. And we usually assess the risk of all these aneurysms from their size. So when an abdominal aortic aneurysm, for example, reaches 4.5 to 5 centimeters in size, it's time to get something done about it. You don't want it to rupture. In the head, we're talking probably only 10 millimeters. If it's over 10 millimeters in size, it is dangerous. And so they may have to actually go in and put a little clip inside that aneurysm to clot it so it won't rupture. Okay, that's aneurysms. Now, what about occlusive disease, the narrowing? That occurs, as I had mentioned, where things branch off. So we see it, for example, in the carotid artery, where the carotid artery in the neck branches, a big one going up to the head and an external one that comes into the face and all. So right at that bifurcation. So we can do things to that, for example. This is just a picture of taking out that plaque out of the carotid artery, and then you just sew it up. Nowadays, they also can do it without an incision, and they put a catheter up, they dilate up that artery, and then they put a stent in there as well to keep it open. So those are the two things that we can do for that particular problem in the carotid artery. Now, I'm not here to tell you about the results of everything and all. I'm just trying to explain a little bit about arterial disease in general. So, okay. Now, besides the carotid artery, we can also have that occlusive disease, that narrowing, in particular areas along the aorta. We can see it where the two kidney arteries come off, the renal arteries. We can see it also down in the iliac arteries. So we define three separate areas clinically, three separate areas of concern that can be treated surgically or may be treated with an endovascular dilatation and a stent, and sometimes combinations of the two. So those three areas are the distal aorta and iliac, down in the groins, the femoral arteries, especially the superficial femoral artery, and then the popliteal artery in back of the knee. Three separate areas that we can treat with our surgical treatment or endovascular treatment. Now, they each have their own set of symptoms. For example, let's try the carotid first. Let's say you get a carotid artery and you have a noise in there, okay? Well, you could have a narrowing of only 50% and get a noise. We call that a bruit. Now, a bruit, back in the older days when I was practicing, we didn't have all these fancy ultrasonic machines and all that would show you pictures of the... all of that, as far as I'm concerned, is nonsense, costing a hell of a lot of money, and it doesn't give you any more information than what I would have gotten with a routine examination, listening to the artery, listening to that bruit, because we got good at listening to these things. And when the bruit noise started to get sharper, a little squeakier, a little higher pitch, that means that it was narrowing down. So then it narrows down to about that 75 to 80% where it can cause symptoms. And if it got worse than that, you may actually hear a to and fro type of noise. That is 90+% narrowed at that point. You don't want to let it get that narrow. Definitely going to get symptoms. Now, we can get symptoms two ways in that carotid artery. Number one, from progressive narrowing, 80%, 75 to 80% or more. Or if you develop a little ulcer on the surface of that narrowing, a little ulcer. In other words, that intima, that lining, breaks open, forms a little ulcer, and then platelets in your bloodstream deposit in there, and it's like pablum in that little ulcer. That can break off and go to your brain. So you can get symptoms from emboli. So, and then there's a special one where you can embolize actually to the retinal artery, and you can get what's called a amaurosis, which is a temporary blindness, which does resolve. In fact, any TIA, transient ischemic attack, by definition, will clear within 24 hours. Now, if it doesn't clear, you may get a stroke. So it's not a TIA anymore. So those are the symptoms that you get from the carotid artery. So I showed you what we can do with it. Now let's go down on that aorta now. Let's talk about aortoiliac symptoms. Well, aortoiliac symptoms will generally mean you fatigue very fast in all of the muscles in the pelvis and in the legs. You fatigue fast. But that's not the only cause of it, obviously. But that is one of the symptoms that you can get. Also, what I used to do very simply is just feel and listen. I put my actual hand on somebody's belly. How do you feel an aorta? You lay them onto the side, all of the chitlins and all go over as you're lying down, and then you can feel the blood vessel. You actually can feel that abdominal aorta, and you can judge the size of it. Now, listening also is very important down there as well. Let's say you have aortoiliac disease. Where do you get the bruit? You listen down in the groins, and you'll listen, and you hear a noise. With every systolic beat of the heart, you get a sound. It's like a harsh sound. Whoosh, whoosh, whoosh. Now, you don't normally hear that when there's normal blood flow. So those things tell you there's a narrowing there. Now, if you don't hear it, it could be that the artery is already occluded, plugged. It's plugged. So the legs are getting the blood flow from arteries that are coming around. They call that a collateral circulation. Goes around the obstruction and then goes into the leg. But that doesn't last long, so that you run out of oxygen very quickly if you're trying to run or do something more extensive, and so you fatigue very fast. That's one of the symptoms. You can also get symptoms like constipation, and because you also get some blood flow down into the rectum as well. And you might even get some lack of blood flow, for example, to the testicles, decrease. In other words, you get ED. You get erectile dysfunction from lack of blood. So those are all symptoms related to aortoiliac disease. So what do we do with that? Well, what we do is a bypass. We can bypass those areas. And we use, say, with a little Y-shaped tube, which goes above, you hook it to the aorta, and below, you hook it to the femorals. Very, very common bypass procedure that's done. So what about femoral arteries now? What sort of symptoms do you get? Well, first of all, the symptoms from a superficial femoral artery occlusion or significant narrowing causes maybe claudication. What's claudication? That's pain in your calf after you've walked for a specific distance. So that's claudication. People describe it as suddenly you just feel like you got kicked in the calf, and then you rest, goes away, you walk that distance again, bang, you get kicked in the calf again. That type of thing. That's called claudication. That's the earliest sign of lack of blood flow in that leg. Okay, so claudication. The second one that you can get, the one that's a little bit worse now, is called rest pain. Rest pain. In other words, you don't have to walk that distance now. Now, you're just lying down in bed at night and bang, you get your pain. The pain is usually in the calf and in the ankle and foot. So that is rest pain. And then the next symptom that's even more severe is when you can get some tissue loss. You get actual tissue loss. In other words, you can get loss of a toe, whatever. But in other words, that's the worst that you can get. So those are in grades the symptoms you get from that femoral artery occlusion that can occur. That's usually treated, as I said, with a bypass, femoral popliteal, or it may be a combination. Maybe they can dilate and put a stent in and do a femoral popliteal bypass as well. So those are the treatments for that. Now, what about popliteal artery and the little arteries beyond the knee? Well, Why am I concerned about that? Because diabetics tend to get much more disease in their arteries below the knee than the average population with just simple arteriosclerosis, with no diabetes. Now, first of all, there's a lot of diabetics out there, 20-something million diabetics in the United States. And they all have problems with their immune system, all that stuff that goes along with having diabetes. But also they get a different type of arteriosclerosis. Now, a lot of times I'll see a diabetic and they get what they call hardening that occurs in that inner lining, or actually under the inner lining, in that second layer, the media, the muscle layer. They get calcium deposit in there. It's called medial calcinosis. Diabetics tend to get that much more than non-diabetics. Well, if you can envision getting your blood pressure, for example, the cuff comes over, compresses the artery. But when the artery has calcium all the way around, it is sometimes almost impossible to compress it so that you no longer can hear a blood flow. So when I get something like that, I say, okay, they're probably diabetic, number one, and number two, they have a medial calcinosis. Now that has implications surgically as well. It's not easy to suture into a diabetic who has medial calcinosis. So you have to take special precautions and use maybe some different material so that it's not going to rip or tear the artery itself. So at any rate, we do distal bypasses for the diabetics. Interestingly, even with that arteriosclerosis and medial calcinosis in those smaller blood vessels below the popliteal artery, the arteries that are in the ankle and foot tend to be open. They don't tend to have that disease as bad. And so we can actually bypass all the way into a foot artery. And that has been done, and successfully done, and feet have been saved with those long distal bypasses like that. And so that is always an important factor. So why do we get arteriosclerosis anyway? What the heck? Why do we get it? Why do we get it? Well, we get it for a number of reasons. There are risk factors, obviously, and diabetes is obviously a risk factor. Heredity is a risk factor. No question about that as well. Obesity, overweight. Now, I'm talking significant obesity. I'm not talking, a little bit overweight. But I'm talking now where your BMI is 30 plus. I've seen BMIs all the way up to 50. But nevertheless, no question. Smoking, way up on the list of risk factors for developing arteriosclerosis. If you're a smoker, you're a damn fool if you have any symptoms related to either heart or peripheral vascular disease. You really have to stop smoking. Vaping does not count. Vaping is no different. And using marijuana, smoking marijuana, again, is no different as far as arteriosclerosis goes. People also who have high cholesterol values. Now, when they say high cholesterol, it isn't just the actual cholesterol itself. It's people who have high, low-density lipoproteins and low, high-density lipoproteins. So those factors as well are part of it. People who don't exercise, well, that usually is the people who have the problem with the weight as well, but lack of exercise. Also, people who drink alcohol excessively. Now, you've always heard the term, a little bit of alcohol is probably good for you. A lot of it isn't. And that does hold true with arteriosclerosis. That doesn't give you carte blanche to go and drink as much as you want. So you got to be careful about limiting the alcohol intake as well. So those are all the major risk factors that people have for the development of earlier arteriosclerosis. So what do we do to work them up? What do we do to work them up? Well, first of all, people come in and they have a symptom. Now, it could be just claudication. It could be that they had a TIA, under 24-hour, remember, symptoms, where you may either lose vision or you may get symptoms of a stroke that only last for minutes or at least under 24 hours. So you've got a symptom. Say you come in, for example, with a blue toe. All of a sudden, blue toe hurts. It hurts. Why? Because most likely a little piece of that plaque broke off, went down as far as it could, and lodged in the artery that goes to the toe. Okay, you're going to get lack of blood flow. It's going to turn blue, and it's going to hurt. So, okay. So, but that's just one example of it. But how do we work them up? Well, what we usually do is do a good, thorough physical and history. So I need those two things. It's not as important nowadays. Nowadays, you don't even talk to your doctor. You just tell them a symptom, bang, oh, you're going to go to a specialist. Well, things have changed tremendously in medicine now. There's not that trust, you might say, between your primary doctor and your patient. So I get off on a tangent about that sometimes. So, but at any rate, what do we do for a workup? We get the history, get a good physical, feel those arteries. You can feel aneurysms, especially the femoral, popliteal, abdominal aorta. You can feel them. I don't need a damn ultrasound to tell me about that. So I can feel it. I can feel a bruit in the neck, and I can listen and hear that bruit in the neck. Okay. But nowadays, they don't even get that. They send you to get an ultrasound of that. Okay. It's great for the cost of medicine to do that way. But, okay. So we get our ultrasound. Now you may want to get an arteriogram. That's a picture of the artery going up. What that tells you then is what the nature of the blood vessel is before and after the plugged area. So you know exactly where you can bypass. So we get the arteriogram, and then we always check the heart, because arteriosclerosis doesn't just happen in one area only, it can happen in multiple. So people with carotid disease most likely will have some coronary disease as well, even though they may not have angina or other symptoms related to it. So we check it all out and then go ahead with the treatment. Okay, I think I've talked enough. So this is Dr. C, and have a good day.